to call the Incarceration Prevention and Reduction Task Force Law and Justice Council October 23rd meeting to order. My name is Jack Covenier and I'm the co-chair. And before we get started, I'd like to read, well, as we get started actually, the following, a land acknowledgement statement. So before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. Our agenda today is pretty straightforward. Stephen's going to start us off with the discussion of the Denver Supportive Housing Social Impact Bond. I'll turn that over to him in a moment, and then we'll follow that with what I anticipate will be a little more extensive committee updates than our agendas have allowed us to do in some of the previous meetings. So with that, anything else before we start, Stephen?
Yeah, I guess this would be an appropriate time to note that Dave Reynolds is here, a longtime member of the task force. And this, correct me if I'm wrong, Dave, but this may be your last meeting with us as you sail off into some tropical sunset of retirement.
No, you're correct. It's my last meeting.
Well, I want to thank you for the years of support you've provided to preventing and reducing incarceration and to the work of this task force in particular. We're going to miss you and hope you have a productive time without a paycheck.
Great. Thank you, Stephen.
Dave, I can't believe it's your last meeting, and you're still doing two jobs, I think.
Well, they're actually they're going to make a confirmation tomorrow with the county council for Raylene King to pick up my role as county clerk, and then Stephanie Kraft will be assuming my duties as superior and juvenile administrator.
Okay, because I remember when a lot of that happened, and you had a lot. And congratulations, Raylene. All right, that's a lot, and you'll be missed, Dave. You've
thank you.
A lot of competence to your office, and thanks for all you did.
I feel I'm leaving in good hands, so thank you.
And I agree with that too, and congratulations from me, Raylene. I'm sure the boat will go well tomorrow. So those local formalities aside, I'm very excited to introduce Katie Bonamassa from the Denver Corporation for Supportive Housing to talk to us about the Denver Supportive Housing Social Impact Bond Initiative, a pilot program operated in Colorado between 2016 and 2020. You have a summary report attached to the original agenda you got. Katie's going to talk to us for a bit about the SIB initiative, and we'll have a chance to question her and learn a little bit more about what interests us. Also, County Executive Satpal Sidhu and Deputy Executive Tyler Schroeder should be on to participate. And we also welcome Maury Ingram and Marcus Warland from the Whatcom Community Foundation, who also have some interest in and background with social impact bonds. Maury's connection to the meeting might be a little bit hit and miss. I think she's on the road, but I see Marcus on the agenda. So let me simply start by turning it over to Katie. Katie, welcome to Whatcom County virtually. Thank you so much for joining us and sharing the information about what looks like an extraordinarily exciting and successful project, and look forward to hearing it.
Thanks so much for the invite. Is it all right if I share some slides?
Absolutely.
Okay, let me get that going here. Okay, how's that look to everybody?
It's great.
Okay.
That looks good.
Excellent. Thanks so much for having me. Again, my name's Katie Bonamasso. I'm a senior program manager with the Corporation for Supportive Housing in our Mountain West division. So we're a national nonprofit organization that has staff in 41 states across the country. And the Mountain West division actually works in Colorado, Montana, Wyoming, and Idaho. And I'm based here in Denver, Colorado. I was actually brought on to CSH to be the program manager for the Denver Social Impact Bond Initiative. So I was kind of the person that sat in the center of the transaction and liaised with all of the different partners in the program, including county government, city and county government, our investor partners, the service providers, etc. So I'm really happy to be here to share with you a little bit about the work we did and are continuing to do. So I thought it would be helpful to start off by doing a bit of an overview about what pay for success or social impact bonds are. So social impact, oops, sorry, that advanced automatically without my help, but it's not a bond in the conventional sense that we know of bonds in the banking world. Really, the way pay for success or social impact bonds work is that you get upfront working capital and you connect that to performance-based contracts. So just by way of example, the way this looked in Denver is that we recruited $8.6 million in upfront working capital from private investors. And that was connected to a performance-based contract where we aim to get people housed and keep them housed and reduce the number of days we spent in jail. If the program was successful, the city of Denver would ultimately pay our investors back with a small rate of return. And I'll share some more details about how it looked in Denver in a few. But some reasons a community might consider using pay for success interventions is a way really to expand and improve outcomes for vulnerable populations. And so in Denver, we aim to serve people who kind of were stuck in this vicious cycle between chronic homelessness, detox facilities, jail, emergency rooms. And what we know is people get stuck in this cycle and it has poor outcomes for the people who are in that situation and for the community. And so our theory was that supportive housing would help break that cycle. And what we learned through a really robust evaluation is that that did happen. Pay for success can also help shift government focus to measuring and paying for outcomes, not just activities. So you might remember, if you've ever had a grant award, you might report on the number of people you served. But what we really want to do is talk about what outcomes happened in that program and really focus our money and on things that we know produce great outcomes. It's also a way to leverage new financial resources to directly fund evidence-based practices. So in Colorado, we had a really hard time funding services connected to housing. And so this $8.6 million we brought into the community to provide services in housing was the largest amount of money that had ever come for that effort. So it really helped us to scale an intervention we knew would work. And then again, to provide an opportunity to bring together diverse stakeholders focusing on meeting the needs of a central or vulnerable population. And so as you'll learn as we talk about the program, there was tons of partners who played critical roles in this initiative. And it was the first time we all sat down at the table together and said, how can we work to serve this one group? So just to share a little bit of a story of how this all began in Denver, this is Reggie Herder. She's the former executive director of Denver's Crime Prevention Control Commission and Office of Behavioral Health Strategies. And she really played a critical role in putting this initiative together. And so what she noticed in her work was that there was this group of people who were experiencing chronic homelessness that frequently were interacting with the criminal justice system, and that there weren't really service providers across the community community that were working together to serve the group. And so she used data to see where people were showing up in all of these systems, like I just described, that kind of cycle that we see people going, on the streets and homelessness, into our jail system and detox facilities, in emergency rooms. And she came up with this list of frequent users that we kind of coined the phrase of Reggie's list. So it was a group of people that needed better care in our community. And what Reggie's list showed us was that this group of 250 chronically homeless individuals accounted for tons of interactions with our emergency system. So 14,000 days in jail, 2,200 visits to detox facilities, 1,500 arrests, 500 emergency room visits. And each year, each person was costing the community about $29,000 for jail days, police encounters, court costs, detox, emergency rooms, and other medical visits. And so what we figured out is that the city was spending approximately $7 million a year on these individuals to cover the expenses I described below or above, apologies. And so, like I said, Reggie's list was a data match. So you see on the right side, we used the Homeless Management Information System, which is our homeless tracking database. We looked at data from the health system and the emergency department, and then city and county jail and detox records. And Reggie's list really included people who were at that center of that number. And when we originally matched the data, there was about 1,500 people on the list. And over the course of the program, that list expanded to about 5,000 because we rematched it every year. So to share some basics about the Denver Social Impact Bond Initiative, like Stephen said, the project started in 2015. The work with our community, with Reggie and community partners to look at the data really started in 2014. We like to say that these projects are labors of love. So bringing together cross-systems partners and many people to do this work kind of takes a long time. But the initiative officially started in 2016 and ran through 2020. Our outcomes were released in July of 2021. The target population from Reggie's list was 250 frequent users of jail, detox, and emergency rooms in Denver. And like I said earlier, the pay for success structure was that we received $8.6 million in upfront capital from 8 private investors. And then there was this performance-based contract that had 2 primary success metrics. So the first was days in stable housing, and the second was reducing the number of days that participants spent in jail. The city of Denver was our outcome payer. So like I said before, if the program was successful, the city of Denver would pay our investors back with a small rate of return. CSH, my organization, was a co-intermediary partner with Enterprise Community Partners. And so the way that looked, CSH played the role of project manager, and then Enterprise kind of handled all of the financial services. So they would receive the money from investors, make payouts to the service providers. The service model used in the initiative is assertive community treatment. So this is an evidence-based behavioral health practice that's a team-based approach to providing behavioral health care. In this model, 80% of the services are delivered to clients in the community. So, once we get people housed, we have on the teams, on the assertive community treatment teams, there's peer specialists, there's outreach workers, there's housing navigators, there's case managers, there's clinical case managers, there's therapists, substance use specialists, there's access to psychiatric care, so people that can get access to medication. And this whole team works to serve a group of clients in community-based settings. So what we know for people who are experiencing homelessness or who have experienced homelessness for long periods of time, that it can be really helpful to bring services to them. Oftentimes we're dealing with a group that doesn't have phones or access to transportation. And so, being able to offer services in the community was a big plus. This service model was delivered by 2 service providers here in Denver. One was the Colorado Coalition for the Homeless. The second was the Mental Health Center of Denver. And then people were housed in two types of housing. The first were single site housing developments. So Colorado Coalition for the Homeless did build one building that was 100 units, and WellPower, or now called WellPower, formerly called the Mental Health Center of Denver, built a development that was 60 units that housed just participants from the program. So that gave us a great opportunity to, interact with people and services, and the teams were actually housed there at those buildings. And then 90 people were housed in scattered site settings throughout the community with housing vouchers. And then we're really excited to have partnered with the Urban Institute, which is a great national evaluation firm that ran a randomized control trial study on this initiative. This is one of the most robust studies on supportive housing that has ever occurred. And so we're really excited to be able to share some of those outcomes with you today. So in the end, after the 5-year initiative, 363 people were housed, and we were able to track their housing stability over a 3-year period. At 1 year in housing, 86% of people were still in housing. At 2 years in housing, 81%, and 3 years of housing, 77%. A lot of times in housing initiatives, you only see housing outcomes tracked for 1 year at a time. So we're really excited to be able to add to the evidence base and show multi-year housing stability outcomes. In addition to that, we saw pretty significant reductions in the number of days that folks spent in jail. So a 38% overall reduction in jail days. We had hoped that we would get to 35%, so we're really excited to get to 38%. The way that the pay for success or performance-based contract worked is we actually had investment in each of the outcome measures. So there was a total of about $4 million invested in the housing stability outcomes, and the housing stability investors earned $4.5 million back. And on the jail day reduction side, the original investment was $4.6 million, and investors receive $5.1 million back. So what we know is that, again, this program produced incredible outcomes for the participants in the program, but also worked out well for the people who invested in the program. Next, I'm just going to quickly run through some outcome slides from the Urban Institute to kind of share a little more specific about what we saw in terms of outcomes in the initiative. So the SIB engaged clients quickly and effectively. This is what we call our engagement analysis. It kind of just shows how long it took for people to move through the steps in the initiative. So because this is a randomized control trial study where people were randomly assigned to the initiative, the providers were just given a name and date of birth of a client and were asked to just find them in the community. And so we had really strong outreach teams that were partnering with the community to locate people. We actually did some pretty cool GIS mapping where we mapped all of the places that people in the program were arrested so that we could kind of see on a map where someone spent their time. And people move quickly through this process. So of those in treatment, 325 people were located, so randomized into the program and then ultimately found. And it took about 49 days to find people. And then of those, 299 engaged in the program. And that took 13 days, which I find pretty impressive because a lot of times, this is a group of people that's not actively looking for housing. So the providers are out there just really encouraging people to enroll. Then they worked to complete housing applications, which took 52 days, and then an additional 15 days to get leased up. We were excited about this part of our analysis because when we were putting the project together, we went to turn to the data to say, how long can we expect it to take to find people and ultimately get them housed? And there really wasn't data on that. And so people have used this engagement analysis to kind of plan for enrollments in other housing programs. So we saw in the SIB that people in supportive housing received more assistance and spent fewer days in shelter on average than people receiving usual care in the community. So you see an increase of 594% of people who are receiving housing assistance, and then a decrease of 35% in the use of shelter days. In addition to that, people in supportive housing had fewer interactions with the criminal justice system on average than people receiving usual services in the community. So these blue lines are our control group. So those are people that received typical services in the community, and then the yellow lines are the SIB participants. So we saw a 34% reduction in police contacts, a 40% reduction in arrests, and a 27% reduction in days in jail. In addition to that, people in the program used less emergency health care and received more office-based care on average than people receiving usual services. So same bars here, the blue is the control group, the yellow is participants in the SIB program. So we saw a 40% reduction in emergency department visits and an increase of 155% of office-based healthcare visits with a psychiatric diagnosis. So what that means is people are getting access to preventative health care, they're getting enrolled in behavioral health care services, and then in addition to that, a 29% increase in unique prescription medications. A lot of times people experiencing chronic homelessness are experiencing severe and persistent mental health issues, and showing people being connected to medications really means that they're getting the care that they need. In addition to that, people referred to supportive housing services had 4 fewer visits to detox facilities than those who received services as usual in the community. So a 65% reduction in detox visits. And then we did put here EMS response. This wasn't a significant result, but it was a decrease. So we wanted to share that EMS, did also go down as well. And because of the services offered in the initiative, approximately half of the total cost of the program per person of the SIB was offset by avoided costs for emergency public services. So you saw a total reduction of $6,875 per person. The most significant cost savings we saw was in the reduction in jail days, but we also saw reductions in ambulance visits, housing assistance, emergency department, courts, police, prison, and public safety, in addition to emergency shelter. So again, we're seeing that not only did this produce good outcomes for the people in the program, but also for the community by the reduction in emergency services. This summer, we were really excited. The National Institute of Justice has a crime solutions clearinghouse. So this is a database where they cite evidence of interventions that work as justice solutions, and the SIB was rated as an effective intervention. And so really what we're learning is that this data shows that supportive housing is an effective justice intervention. And so it can be used in scale and is used in, at scale across the country. But it was great to have this recognition with the National Institute of Justice. In addition to that, the SIB has informed the national debate on the root cause of homelessness and the role of policing. So here you see Representative Maxine Waters. This is her giving testimony to HUD with the SIB outcomes. There's also a tweet here by Senator Michael Bennett just touting the results, and then a Bloomberg article that really raised up the results of the SIB that shows that supportive housing can really help break this street to jail cycle that we see people stuck in. So this has really helped contribute to the national debate and has put forward supportive housing as an intervention. And finally, just wanted to say that, the outcomes in the SIB have been used to scale additional initiatives in Colorado. So there is a follow-along initiative called Denver Housing to Health, or CIPRA. And this initiative aims to serve 125 people in the very similar model to the one I just described, except for this time around, we've added an additional outcome measure, and that's net federal reductions in Medicaid expenditures. And so when we were able to look at the data on the back end of the SIB, what we saw is that there was significant reductions per year in the use of Medicaid services because people were moving into more preventative healthcare. And so in the CIPRA project, the city of Denver is the outcome payer on the housing and jail outcomes like they were in the SIB, but the federal government has actually stepped up and is going to be the outcome payer on that Medicaid reduction outcome. This is a 7-year initiative. We are 2 years into this 7-year program. We're continuing to see similar outcomes in the initiative, and we're really excited to have additional reporting as we kind of move forward. Our first big report will be released in about a year. And then in addition to that, the state of Colorado used our outcomes in the SIB to say they wanted to do more supportive housing across the state. And so we saw a partnership through the American Rescue Plan Act, where the state housing authority committed vouchers for 500 people, and the state Medicaid office committed service dollars for 500 people. And we're working with 30 providers across the state to scale this intervention using ACT-like services in a supportive housing setting for people who are frequent users of emergency health care in Colorado. And so this has been a great, it has helped to propel on other initiatives across the state in Colorado. So that's all I have in terms of presentation. I'm certainly happy to answer any questions you all have about the SIB or follow along initiatives. But thank you so much for listening.
Thank you for that really comprehensive presentation, Katie, and congratulations on this work.
Thank you.
It's stunning. Mike, I'm going to start out by just asking my own question, which is I'm reading between the lines, and it looks as if in Denver there was a waiting capacity. There were housing choice vouchers available. There were landlords ready to take them. There were capacities within the treatment systems and social service systems. Am I understanding that correctly? Because that's an issue we're having here locally. Is the systems are not ready to take these kinds of innovative practices to help people.
Yeah, that's a great question. And that's actually part of what took so long for us to put the project together on the front end. It actually took years of planning. And just as examples, the 2 new buildings that were part of the initiative, typically the way that our state housing and finance authority allocates affordable housing tax credits, they typically approve 1 tax credit project per region per year. And so we really worked closely with our state housing and finance authority to say, this is an unprecedented amount of service funding coming into our community, and we really need the housing that matches it. And because of that, we saw those low-income housing tax credit approvals and voucher allocations, because with supportive housing, you often need project-based vouchers to, make the units affordable for people who are experiencing long-term homelessness. And so that was a many-year advocacy effort that led to many units coming online at the same time. I will say, new construction is tricky. I've never seen a building open on the date we think it's going to open. And so we did have some construction delays in the project, which impacts our ability to earn days in stable housing. And so we actually had to add a few additional participants to the program to kind of make up days that we lost because of construction delays. But you're right that it does require that you have housing in order to do this type of work. And I would say, working with all of your community partners is really important to kind of put those pieces to the puzzle. But when you have, almost $9 million in service funding, it does make it a little bit easier, because a lot of times people say it can't be housing without services. And when you're coming to the table with additional resources, it can be helpful.
Thank you. And I'm going to turn it over to Mike Parker. And Katie, I just want you to know that Mike was the one who here locally first saw your outcome report and
Awesome.
identified the value of the project and helped excite all of us to inviting you here. So Mike, you got a question?
Great.
I do. Katie, thanks for your presentation. Yeah, your partner in crime, Debbie Thiel here, did a nice job sharing in a couple of different forums that some of us attended. And obviously, you know, the whole purpose of this task force that you graced your presence with today is all about the subject you're talking about. So just thank you so much. We have some of our own thoughts, and I know our execs on today's meeting too, and might be able to share, because I think we're trying to lift something like that ourselves. But I have a couple of questions, and they get at a couple areas. Stephen did one. I'm going to riff off his question. You mentioned that there were 2 new construction projects that housed some. I wasn't clear what percentage were served in these brand new buildings and projects, and did you use any scattered sites? And then I've got a couple of other quick questions too.
Yeah, so our total target population was 250 and 160 were single site developments. And then so 90 were scattered site vouchers. And so we partnered with our state housing authority in Colorado. We have what we call a state housing voucher that is money set aside from our state legislature through marijuana tax revenue. And so it's a flexible resource that we use in our community to serve people who are experiencing homelessness. So the state housing authority committed some of those vouchers. In addition, we had some continuum of care vouchers that were committed for the initiative, but it was mostly state housing vouchers through the state of Colorado.
Okay, that's exciting. And I'm excited about your new one. So I'm going to ask you a little bit of question about your new one, because you talked about getting some reimbursement from Medicaid, right? So I'm assuming that Colorado is using a Medicaid waiver process. Is that right? To have the federal government then come in and be a party to your pay for performance, or essentially monitoring your reduction in overall Medicaid expenditures. Could you talk a little bit about that?
Sure. So actually, the initiative is through CIPRA, and it's Social Impact to Pay for Results Act. And this is federal legislation that allows the federal government to be an outcome payer in Pay for Success initiatives. So they've done a couple of rounds of funding, and the requirement is that you must be able to prove federal savings in order to do so. And so the evaluation threshold was really rigorous in our process of approving. It was actually something that was started in the Obama administration, paused in the Trump administration, and then we were actually issued our money right when Biden started office. And so it was kind of something that that took a long time to get off the ground. But we met with the Department of Human Services, the federal Medicaid office, all to look at our data, and they were able to agree that if we could show savings, that they would make those payments. So Colorado, unfortunately, does not have a Medicaid waiver. We are working really hard with our state Medicaid office to find a solution like that for the long-term funding for services and supportive housing. We've been working on it for about 10 years. We're getting close through that initiative that was piloted through the ARPA money, but we're not quite there yet.
Okay, great. So there's another venue, which is exciting, because that would mean that might be eligible for Washington State as well. And then just my last question was a little bit on recruiting the investor. So obviously you've characterized the investors as obviously seeking some profit, but you also mentioned it's modest. And you talked about some tax credit, and I know you've got buildings going on, and I kind of have a sense, I think most of the task force has a little bit of sense how those tax credit buildings are structured and how the funding is structured for those. But back to your service partners, I mean, would you characterize this as it's a lower rate of return than they normally did? I know you have Northern Trust, you have, for-profit companies in there. What entices them? Is the rate of return similar to what they would have gotten elsewhere? Did they do this as kind of, could you explain the motivations behind that? And then how likely or how difficult is that for communities to follow that blueprint, right? How easy was it for you to attract those investment partners that would be able to accept the modest rate of return that the city of Denver did and still be happy with those outcomes?
Yeah, so most of our partners were actually philanthropic. We did our Northern Trust Bank was our largest investor in the SIB, but they have a requirement to do community investment every year, and so this investment actually fell under that arm. And so really their goal is to do things that help the community. And part of why we kind of divided our outcomes into buckets was to kind of help with our investor recruitment. So we had some local foundations and local philanthropy where their giving was in the justice realm and they really wanted to invest in the jail day reduction outcomes. And some local foundations and philanthropic partners that were more interested in the housing stability and addressing homelessness. And so by allowing people to invest in the outcomes that help to further their missions, that really helped us in recruiting money. And by the time we got to the second project, we had investors approaching us because of the innovation of the work, because of the great outcomes we're seeing, people just really want to be a part of it. 8 investors in the SIB, that's another reason. We had so many local people that just said, I want in for 500,000. Can I be a part of the initiative? This is so cool what you're doing. We really want to take part. And, in the second initiative, we were able to limit the number of investors down to 4 because there were so many people who were interested in being involved. And it just makes it a little bit, there's more cooks in the kitchen, the more people that you have coming into an initiative like this that's already very partner heavy. And so it wasn't as hard the second time around. And I think you'll find that people want to be involved in innovative initiatives like this. So it's not as difficult as it seems like on the front end.
Great. Thank you, Katie.
Thanks, Katie. Deborah Hall.
I have a quick question, Stephen, if you don't mind. This is Jason.
Well, Jason, Deborah Hawley's had her hand up for just a bit. Let me take her and then come back to you.
Yep, sounds good.
Okay. Deborah?
Yeah, so because most individuals with substance use disorder don't accept treatment of their own volition, I was wondering how you address the challenge of dealing with this when simply by creating housing, which of course is a very good idea, I don't know that that would necessarily change an individual's mind on whether they're going to accept treatment or not because they're in housing. How did you deal with that challenge?
That's a great question. So in supportive housing, we use a couple of primary approaches. The first is housing first. And so what we know is people need a place to sleep and to shower and to eat to address challenges in their lives. So, how are you going to stay on medication if you're carrying all your belongings in your backpack and your backpack gets stolen, or you need a refrigerator for some of your medications? Or, how are you supposed to show up for an appointment if you don't have a phone, those sorts of things. So we use housing as the platform, and then we apply what we call assertive engagement strategies. So like I described before, these teams are very diverse in terms of the types of position and staff. We try to pick staff that really reflect the population. And I think a lot of times some of this initial engagement really comes from peers, people who have been in the situation that the person is in. And our kind of theory is it's not the participants' job to engage with us. It's our job as service providers to do everything we can to help them engage in services. So maybe it's offering a different type of service. Maybe it's continuing to try. Some people engage right away. Some people it could take a year, but we're still knocking on their door every day and saying, hey, we're still here. Do you need food? Can we take you to a doctor's appointment? Can we bring you to lunch? Grab a cup of coffee. We're really trying any strategy possible to engage with folks. And so we see it as our job to help them engage. And more often than not, the data really bears out that if you don't require people to do things and you deliver a package of services that folks are interested in, that they do engage in services in the end.
Okay, I had another question.
Sure.
Thank you. So what percentage approximately of individuals that have substance use disorder would you say, once they're in housing, willingly want to accept treatment, for example, Suboxone for opiate addiction? Like, what is your success rate for that?
Yeah, that's a great question. I don't know that I know the exact data off the top of my head, but I can ask our evaluator and get back to you. Both Colorado Coalition for the Homeless and the Mental Health Center of Denver are providers of Suboxone, and there was a large number of participants who did enroll in that type of treatment and take medication. That was included in the statistics where we saw a 29% increase in prescription medication. And I think, you know, on the onset, between 70 and 80% of people enrolled in the program either had a substance use disorder or behavioral health challenge, and all engaged in services in some way.
That's great. I just have one more question.
Sure.
Maybe I should already know this, but I was just curious as to what percentage of your jail population is comprised of individuals who, you know, are the repeat offenders from the homeless population. Like, what percentage of the jail population is comprised of this group of people that we're talking about? And then I'd like to know from someone in Whatcom County what our population is of that group.
You know, I don't know that I have data in that way, but what I know is that, you know, police spend an incredibly large amount of time spending with people who have been committed or been charged with crimes that are connected with homelessness. So I think there's like this false narrative that people experiencing homelessness commit violent crimes. We actually looked at the data, and you know, the regular population commits violent crimes at a much higher rate than people experiencing homelessness. And I think in 1 year, when we looked at the data, it was like 6,000 hours that police spent engaging with people for warrants or for offenses that were connected to homelessness. And so we'd rather see the police be able to work on the violent offenses or other crimes like that. And so why not get them in housing? But I can ask about the overall population and how many we saw in frequent use.
Okay,
And
thank you
Deborah,
very much.
we'll try to get data from Caleb on local figures like that.
That would be great. Thank you.
So I'm going to go next to Jason, but I want to interject here for sort of meeting management purposes. We've got limited time left with Katie. She's been very generous. I have limited time with Maury Ingram and Marcus from the Community Foundation to talk to us about their interest and experience with social impact bonding. And so I want to make sure fit those in, and then we get to Executive Sudo. So I'm going to ask people to, rather than piling on a couple questions at a time, limit themselves to one question. And we're going to take a few more questions before we let Katie go. So Jason, you were very patient. Thank you. You're up now, and then Raylene.
Yeah, thank you, Stephen. And sorry about that. I'm on my phone, so I couldn't see everyone. But Katie, first, like, thank you so much for that response, your response to the question of folks not wanting to engage into treatment. We understand that recovery is a lifelong journey for a lot of people, and it's and that's just what it is. So beautiful response. Thank you so much for that. At the end of the day, people just need to be housed, regardless. So Katie, the question was, you said Denver had this coalition, or there is a coalition, but then you had other service providers invested into this process. I mean, without naming like the organizations or anything like that. But when you say service providers, like, what do you mean about that? Like, yeah, like, because we have youth and young adult service providers. That's what I oversee. And then we have adult service providers. Was it everyone coming to the table and really unpacking this kind of vision?
Yeah, we actually contracted with only two. The first was Colorado Coalition for the Homeless, and they are a large nonprofit that actually develops housing, administers vouchers. They also have a federally qualified health center, and they have what they call their Housing First Department, which actually houses, I think at this point, 8 assertive community treatment teams that they deploy to work with folks with the toughest challenges. And then the second service provider was the Mental Health Center of Denver. So this is a community mental health center that specializes in behavioral health services, but they also own and operate their own housing. And the housing that was developed, they did a 60-unit development that was specifically for this initiative. It was their first full development. They had previously purchased buildings and used them as group homes or other treatment facilities. And so it was their first foray into affordable or supportive housing. We did a pretty robust process to select providers. So we knew we were going to be serving a group of people because of the data that had very high needs. And so we tried to pick the highest performing providers in the community. And so I would say you have to look at your data and whoever you decide to serve. For example, there have been pay for success programs that serve youth, but you would want to make sure that you are picking youth providers to do that. And in our RFP, we said we were looking for providers who did housing and behavioral health services and had some ability to bill Medicaid, because our thought was that over time, the providers could increase their billing to Medicaid. That didn't pan out the way we hoped because we haven't really seen those changes in the Medicaid system. But we knew that we could get more bang for our buck if the providers were able to bill some of their services to Medicaid. And so the way the budgets worked is that we paid what the gap was between what the budget is to do a full ACT team, what Medicaid covered, we would subtract, and then that $8.6 million filled in the gap for the 5 years. That was probably way more information than you were looking for. Sorry.
No, that's perfect. Thank you so much. That's actually, you said something in there that yes, perfect. Thank you.
All right. Thanks, Jason. Raylene.
Thank you. Thank you, Katie, so much for this presentation. My question has to do with substance abuse. I know you've touched on it quite a bit already, but did the data differentiate between those using such as heroin to those involved in methamphetamines and fentanyl? Because that seems to be a struggle with certain drugs to get people into treatment and housing.
Yeah, we looked at diagnosis based on Medicaid claims. And so sometimes in the claims, it will say methamphetamine addiction or, specific substances that folks use. Sometimes it would just be like generalized substance use disorder. And so we have some data on what types of substances folks use. But I think if what you're getting at is that it can be hard to house folks who use methamphetamines, we kind of see that here too because of the damage that it can do to units. And, we experience that struggle the same as everyone else does and move people. We try our best not to evict people or exit them from the program. We just try to find a more suitable unit for them if stuff like that comes up.
Thank you.
Katie, I know that fentanyl was really sort of hitting the western part of the country about the time you were wrapping up the services of the pilot project. So I'm wondering if any of these follow-up projects are sort of zeroing in on the primary drug of choice issues in looking at continued effectiveness.
Yeah, we certainly are. And, particularly in the buildings, we have to change our policies and make sure that everyone's trained in the use of Suboxone and injectables. We've certainly had overdoses in the properties. And so the service providers, which are the same in the follow along initiative, really are doing their best to address the challenges, just like you said.
And my last question is, I know the ACT model is an extremely rigorous regimen and requires a lot of certification and training. Did you have 8 ACT providers? If I understood your data correctly, did you already have those in place, or did you have to develop those for the project as well?
We picked providers who were familiar with the model, and we actually call it modified assertive community treatment because, like you said, ACT is an evidence-based approach used in the behavioral health world that's for people with specific diagnosis. So in order to qualify for an ACT team, you would have to reach certain diagnostic criteria. And why we call it modified is because in the SIB and in CIPRA, we recognize that this community team-based approach that was developed through the ACT model works incredibly well for people with long histories of homelessness and severe and persistent mental illness and substance use disorders. And so we applied the ACT model to everyone in the program, regardless of their diagnosis. So that's why we called it modified. There was also some fidelity markers that we couldn't quite get to, like the 24-hour access to care was hard for our teams to do. And so there are some places that we don't quite get to fidelity, but the principles and the staffing structure really is what we pay for and what we know works.
Great, thank you. And the last, maybe most important question is, are there any of you still around who might consult if as Mike Parker said, we actually get some traction locally on exploring this kind of approach?
Yeah, CSH works all over. I worked on a Pay for Success initiative in LA. I'm working on one in Anchorage, Alaska. And so we're happy to talk with you. Mike, if you're connected to Debbie Thiel, she's the managing director of our Western US. And so she's a great place to start, but we would love to support your work. Absolutely.
Thank you so much, Katie.
Yeah. Thanks, Katie. We'll let you go. I appreciate your generosity of time and the wealth of information you gave us. And again, congratulations on the project and the continuing work.
Thank you so much. You all have a great afternoon or morning, I guess, where you are. Yeah.
Yeah.
Thanks, everyone. Bye-bye.
Thank you. I want to offer Maury and Marcus from the Whatcom Community Foundation whatever time they would like to talk about social impact bonds and the potential they see in that model and in its application here in the local community. Maury?
Good morning. Hi, everybody. Apologies, I'm on my phone, so I'm going to stay off video. So that was a really helpful presentation. I do hesitate to represent that we have experience per se with social impact bonds. We definitely have a relentless interest and curiosity about them. And we were first exposed when we learned about the program that was led by the United Way in Salt Lake City related to childcare and sort of family services funding. And so we've done some research on that, have spoken with the folks at the Sorensen Institute, which is at the University of Utah. And I think they played a somewhat similar role to what I imagine the Harvard Kennedy School played with regard to the Denver work. And so looking at how to construct the metrics and then obviously, as Katie noted, a really multi-pronged effort in Utah around trying to address that work. And so I think we are similarly curious and have a really strong belief that there's a lot of potential for social impact bonds. We do impact investing work in the community, and this is the kind of thing that I think is just a great natural extension for Whatcom County to look into. And to, I think one of the keys that I think everybody on the call understands is there's a real critical need to have a shared agreement around those metrics, and then to have the buy-in, obviously, of the ultimate payer. But I think, as Katie said, people love innovation, people love effectiveness, and if you can craft the right strategies, I think attracting the resources won't be problematic. And I guess the last thing I would say with regard to the community foundation is for us, it's certainly an area that we're interested in and would just be happy to be a resource and thought partner and play whatever roles might be useful in going forward. And I asked Marcus to join me because he's the controller at the community foundation, and whatever our role he would have, he would play a central part of that.
Marcus, anything you want to add to Maury's comments?
No, I think Maury covered it. Thank you for inviting us and having us be a part of this. So it's very valuable for us to hear and be a part of as well.
Our pleasure. And I hear there's a potential partnership there if we start to explore this more actively.
Absolutely.
Great. Thank you. Any questions for Maury? Okay. We had Executive Sidhu on for a couple minutes, and I know he had some conversations with the Community Foundation and might have had something to add to this conversation, but he's not on now. So is there any further discussion amongst ourselves about the presentation, the general model of social impact financing for this kind of work, and the obvious methodological rigor that Denver went through with their SIB project in translating that to any local work? Okay, thank you so much for participating in that part of the agenda and the conversation. Jack, I'm going to turn this over to you to start through the committee reports.
All right, thanks everyone. Thanks for that presentation. And I believe the first committee report we have scheduled today, so the order we have is joint behavioral health and legal and justice systems, then anything from index, and then the legal and justice systems committee on its own, steering, crisis stabilization, and behavioral health. So let's and I'll flip some of these back to you, Stephen. Let's proceed in that order. And I'm not quite clear on who's doing joint behavioral health and legal and justice systems, whether that's Mike or Eileen or whoever, Arlene, but if somebody wants to start us off, that'd be great. Don't be shy.
I was actually out on the joint meeting, so I don't know if Mike Parker or Dan Hamill or Arlene would be able to fill in. That'd be great.
Dan did send an email this morning. He unfortunately is unable to be here, so that's Mike. Were you there, or Arlene? And if not, we can carry this item over.
I think maybe we should carry it over.
I am gathering that as being wise. So, okay, we will do that. Do we have anyone here from Index? Because I am not seeing that we do. All right, how about going once, twice? How about legal and justice? How about that one, really?
Thanks, Jack. We had a fairly robust conversation about the Ann Deacon Center for Hope. The hope was that law enforcement and EMS services would be using it more than they currently are. And so there had been a proposal of possibly doing some type of a survey. But it kind of seemed like we didn't know if that would be beneficial, that we knew that drop-off times and some of the restrictions were preventing law enforcement and EMS to be utilizing it to what the intention was for the Ann Deacon Center Hope in the beginning. I could be, it's still being used. It's just law enforcement are finding that a lot of the individuals that they have and EMS are ending up at the hospital. And the hospital is using the Ann Deacon Center of Hope for transferring some individuals. So then there was questions on, do we need to reevaluate how it's being used, or do we need to make some changes to what the intent was? Stephen, did you have any more comments, or did I sum that up?
No, I think that's a good summary, Raylene. Thank you. I know that Perry has been working on visor cards for law enforcement to clarify and speed up the inquiries about possible drop-offs, and working with the treatment providers on both sides of the facility on admission protocols as well.
Thanks.
Yeah, and I think we'll see if there's any questions. I'll probably, Perry, if this is okay with you, switch to Perry after this, because I was at the crisis stabilization meeting this week, and that same topic came up, and we had conversations about it there as well. I think Under Sheriff Chadwick had some comments, and I had some. Anyway, so I think that topic is being discussed. But before we go to the crisis stabilization, is there anything more from Legal and Justice or any questions for Raylene? All right, I think it works nicely to hand it to you, Perry, because you can kind of pick up that thread and talk about what we talked about, which sort of addresses what they just talked about.
Sure. Good morning. Perry Mowry. I'm a Response Systems Division Supervisor with the Whatcom County Health and Community Services. I'm also the chair for the Crisis Stabilization Center and Deacon Center for Hope, IPRTF subcommittee. We touched on data for 2023 thus far, since we had completed the third quarter. Did a little bit of comparison relative to 2022 bed utilization, referrals, etc., and 2023. The detox average quarterly referrals received in 2022 was 671. That was pretty similar for the quarter's average of 672 in 2023. The triage average quarterly referrals increased from 2022 at 364 per quarter, and it increased to 411 per quarter in 2023 thus far. Law enforcement referrals to the Crisis Stabilization Center in 2022 was a total of 75, which is about 19 per quarter, and the referrals to the Crisis Stabilization Center for law enforcement in 2023 is averaging 21, so some increases there. We also touched base, as others had made reference to, law enforcement and first responder drop-offs. Some of the action steps that we've taken that we touched on briefly was a streamlined protocol in which law enforcement and first responders basically place a screening call to the Crisis Stabilization Center. I won't go into all the detail of that, but it is outlined on the visor cards that were made reference to. That were issued, sent out to all of the law enforcement offices in Whatcom County to increase that efficiency in terms of the drop-off. That is effectively to reduce the time that law enforcement and first responders are spending at the facility as they drop an individual off that's in need. Some of the planned actions that we touched base on was use of the Response Systems Division Behavioral Health Aid, a new position that provides transportation within the community. So detox and triage will be using that individual if a person is dropped off by law enforcement, first responder, and for one reason or another does not meet admission criteria. They can use that person Monday through Friday, 9 to 5 as available. But to cover other gaps, because of course that's not always going to occur Monday through Friday, 9 to 5, I committed to working on creating a flex fund contract with the providers so that they could utilize that flex funding for transportation of individuals that are ineligible for admission at times when we don't have transport available. That way that cost isn't simply assumed by the providers, and and again, that would reduce the time that law enforcement would need to spend there, because I think historically the orientation was moving towards using law enforcement and first responders as transportation if the person wasn't admissible, and that's not the best use of their time. Happy to have sent out responder visor cards, just a quick reference phone call. It sort of runs down through that quick access for law enforcement when they are going to use the Deacon Center for Hope. And just to sort of wrap that piece up, We talked about the referrals that had occurred to the Crisis Stabilization Center from law enforcement, being a total of 34 to triage and 34 to the detox facility as well. We touched on 12-hour holds. We've talked about this a bit before in the Incarceration Prevention Reduction Task Force meetings. RCW 1031-110 allows for its legislation that was put in, a statute that's put in for law enforcement to be able to use the Crisis Stabilization Center as a 12-hour hold. Some of the challenge that we run into there is that our Crisis Stabilization Center is a voluntary facility. And so that creates some concerns, of course, relative to law enforcement using that for a 12-hour hold. So we had some discussions about that, talked about some of the challenges that are going on there. And I'm continuing to communicate with law enforcement and with both the City of Bellingham Prosecutor's Office as well as the County Prosecutor's Office relative to that. They play a role in identifying what low-level crimes might be considered for diversion from the jail and utilization of these 12-hour holds at the Crisis Stabilization Center. We also touched base on the lease contracts for the vendors as well as service agreements and talked that over briefly. We also talked about the Peace Health's use of the Ann Deacon Center for Hope for referrals. Real quickly, in 2022, Peace Health made a total of 522 transfers to the Ann Deacon Center for Hope. That's an average of 131 per quarter. In 2023, so far in 3 quarters, there has been 454 transfers, so that's 151. So an increase of 20 individuals per quarter at this point in time that are being transferred from Peace Health to the Ann Deacon Center for Hope. Lastly, in our steering committee, it was suggested that I touch base briefly during the subcommittee meetings for the Crisis Stabilization Center on the 23-hour Crisis Relief Center. If folks are unaware, Whatcom County has received a $9 million capital fund from Department of Commerce. And so I just updated there generally. This is related to Senate Bill 5120, which is legislative language that is creating an statutes for the 23-hour Crisis Relief Center. There's been discussions and there's a work group that's occurring in the executive's office relative to that planning. It's not gone a long ways at this point, but there are certainly some steps that have taken place, and I'll continue to update folks in that regard. And that's what I have.
Are there any questions for Perry? All right, I want to circle back slightly to the index committee because I received their minutes. Thank you, Jill. And interestingly, on those minutes, again, we were discussing the Crisis Stabilization Center and those statistics. So what kind of seems obvious is that we're getting a lot of interest in that topic. And Perry, is it fair to say from our meeting, I think one of the issues that keeps coming up is accessibility for law enforcement and the original intention, for example, of a very quick drop off. I think one time we talked about 10 minutes. What I am hearing fairly consistently is when that goal was set, it wasn't understood how long the processing would take by the staff that are contracted to take people in. So in other words, the part of the challenge, at least with the goal of that 10-minute drop off, is how long it takes to process somebody in. Is that correct?
Yes, I think that that's accurate. Didn't understand the technical aspect of the drop off, intaking information and so forth. And so, of course, the piece that I'm working at is to say, well, law enforcement, for example, may be able to share a little bit of data in regard to intake, but not a lot. Oftentimes, the individual needs help. They need to drop that person off. And so I really have focused in on the fact that, in my opinion anyway, part of this issue has really been viewing law enforcement and our first responders as transportation if the individual is not appropriate for the admission. They need a higher level of care, et cetera. And so holding law enforcement, first responders. And so working in that particular aspect and saying, we don't need to do that. We have an alternative for transportation in those particular situations. So long answer to a short question. Sorry, Jack.
No, that's okay. But I think a lot of us, if we've been sitting here a while, we know what the original goals are. And it's fair to say, not just from COVID, but just when you execute a facility of this kind, you will find unintended challenges that are naturally going to exist. That's just the nature of it. But I think it's important to continue a concerted effort at looking through the lens of this task force for reducing incarceration. We want that facility to be used to reduce incarceration, which in part is accessibility to law enforcement and quick drop-offs. And I think that regardless of the challenges, can't get lost in the goals. And I understand there are many other benefits to that center, looking through behavioral health lenses and other lenses. This isn't the only lens, but here at this task force, that's a lot of, we care about the other things, but our mandate is to try to reduce incarceration. It's important that we continue those or encourage those efforts that will allow that to more easily happen. So thanks for your efforts on that. And I just thought it interesting, yeah, because the minutes for index committee, you probably see it in your packet, say item number 2, potential survey of providers, users, law enforcement, and EMS about using the Ann Deacon Center for Hope Crisis Stabilization Facility. So, you know, there's a lot of interest in this. It's a great facility. And I think we all agree the more we can use it to reduce incarceration, the better. Stephen.
Yeah, thanks, Jack. Perry, I continue to be surprised at how many roadblocks we run into. And I noted in your report that we've got another roadblock with the 12-hour involuntary hold. You know, we built the facility thinking it would work as a drop-off in crisis stabilization. Then we realized, well, we needed special certification for that, and the providers needed training, and that took forever. And then we got that taken care of. And now I'm unclear. If I understood you, you said it's a voluntary facility, so we still couldn't use it for 12-hour statutory involuntary holds. And I don't understand how we got whopped in the side of the head again. Can you explain that?
Sure. So the 12-hour law enforcement holds is part of RCW. It's part of statute, and specifically is 1031-110, RCW 1031-110, and it does allow for 12-hour holds for individuals that are transported to the Crisis Stabilization Center. The challenge is, I think, that law enforcement has concerns that it is not that it is a voluntary as opposed to involuntary. That is, that the individual can leave of their own volition, even though a 12-hour law enforcement hold is placed on the individual. The staff at the Crisis Stabilization Center cannot go hands-on with an individual. That is part of the certification. And so I think that, you know, so that clarification that we absolutely can use it. We're certified to be able to do that by the state. The triage side specifically, Compass Health currently provides our mental health triage and stabilization, and they are certified and have trained staff in place for that. The ongoing concern has been essentially, let me sort of run through, if law enforcement, you know, brings an individual, they want to place a 12-hour hold. The individual that information is shared with them. They're told, you know, you're on a 12-hour hold. The staff would work with the individual to remain as long as they needed to remain from a clinical standpoint in terms of being stabilized. And then if the individual did leave, the statute actually specifies that the provider would make contact with the law enforcement office and inform them that the individual had left before the 12-hour time frame had come up. And so at this point, the providers are ready to do that. The prevailing belief at this point with law enforcement, as I understand the discussions, has been that the individuals would likely not stay, that there wouldn't be a purpose in dropping them off, that they can't be held against their will, And so utilization of it is, is a concern from law enforcement. A second component of that is that, once again, this statute references the prosecutor's office in being a part of identifying the charges that would be allowable to defer relative to, obviously, law enforcement. And the county prosecutor's office has expressed at this point in time that there are concerns about the liability for the county in diverting an individual from an arrest charge to this 12-hour hold. That's being reviewed at this point in time, or has actually been reviewed by the county attorneys. And I'm not privy to that information. What I've been informed of in that regard is that the sheriff's office in this specific example is the client of the county attorneys. And so there's a privileged, you understand that there's privilege in terms of confidentiality between the attorney's office. So sorry about all that detail, but that's basically where we stand at this point. I'm certainly willing to continue to communicate with, both law enforcement offices as well as prosecutor's office in this regard, in hopes that we can, continue to consider utilization of this. There has not been any 12-hour law enforcement holds placed at this point in time, so we don't have, information along those lines. So hopefully, Stephen, I've answered your question. If there's a detail I missed, please let me know.
I guess that was responsive, Perry. Thank you. I guess I'm concerned. This was strongly encouraged by the sheriff's office. It was planned, and as I said, multiple steps went through to secure this capability. And it seems to me, I have my fingers crossed that the next couple of years we're going to do a heck of a lot of new program planning. And it didn't seem like we caught, half of the stumbling blocks on this one. And I hope we can do better and things can go more smoothly as we build out the system in the next couple of years. I say that knowing I won't have quite as direct a hand in that oversight with my term expiring, but it would be good if we could smooth out those rough spots.
And I think that it's helpful, here of where, Jack had pointed out that it's like, well, there's other lenses, there's other, sort of approaches here. And certainly other than incarceration reduction, and diversion process, but the behavioral health aspect, the thought had certainly, crossed my mind that a number of individuals are ending up at Peace Health via law enforcement, transport. We don't have that data, to be able to collect it in that way. But then those individuals are being, transferred. A large number of individuals are being transferred from Peace Health to the Crisis Stabilization Center, not in the direct way that we want. And also our bed utilization of the Crisis Stabilization Center, again, and this is not from law enforcement per se, although that's increasing somewhat, but not the 12-hour law enforcement holds. So I think that's still a nut to crack, and I think that there's still opportunities there. I tend to be pretty positive in those regards, and so I think the provider staff are certainly open to that process as well, by virtue of the streamlined admission process and some of the other steps that they've taken. So.
Thank you, Perry, Stephen, and Raylene.
Thank you. Perry, this might be not possible at all, but what struggles would it be to change the licensing for the Hand-Deacon Center for Hope to allow for hands-on and holds that they weren't allowed to leave?
Great question, Raylene, and we actually touched base on that just briefly during the subcommittee meeting. The level of care in Washington that you're talking about, describing is referred to as an ENT, evaluation and treatment. There are some ENT programs that do exist in the North Sound region, and at least from my perspective, we may want to, pull in, other more knowledgeable individuals, but there's two components to that. One is really the design of the facility. The facility was designed as a voluntary facility, as you know. A residential treatment facility is what it's actually technically certified as a building, and the providers. And the other, dynamic is then a certification, and actually Compass Health provides ENT services within the North Sound region. And so that's certainly something that they're capable of, but getting a certification for the facility and the providers themselves for an ENT level of care. That hopefully answers your question.
All right, thanks everyone. And thank you, Perry, for wearing multiple hats on this and for communicating with us. Stephen, I think we've got left, if I'm not mistaken, Behavioral Health and Steering Committee. If you want to take those.
I'd be glad to. And I note that Mike Parker has had to drop off. So I think we'll defer the Behavioral Health Committee update. And Councilmember Buchanan, would you inform us on the Steering Committee?
Sure. Thanks, Stephen. Hey, good morning, everybody. As you know, what the Steering Committee, one of their main tasks is setting up agenda items for task force meetings, full task force meetings. And so we've been busy looking at things like the one we just had, the social impact bond. And we're also looking at a couple of upcoming things that I wanted to point out. One is training that we're going to be receiving on communications from our consultant Pyramid. And maybe Jill can give us just a preview of when that might take place. It'll be in the next couple of months. But we haven't got it. I don't know that we have it scheduled per se for any particular meeting. So Jill.
Hi, everyone. Yes, we do have it scheduled. The November full task force meeting will be a training of sorts with Pyramid contractors and the full task force, and making best use of training tools, or communications tools going forward. And then we have a few of us on staff who will be training independently with Emily and Sakara in a couple of weeks.
Okay, thanks. That was part of the contract that we get some training for our members, so we can carry on, some of these communication efforts past the contract. The other thing that we touched on with Pyramid was the recruiting effort for vacancies on the task force that Stephen kind of mentioned. We're going to be going through some leadership challenges next year, and Pyramid is going to help us out in the next couple of months to get the word out that we're recruiting for membership for those vacancies. So we'll hopefully get some applicants out of that. And then the other thing that was on that we talked a little bit about was the public defender's workload case study. And I don't think Maya's here today. I was hoping that she could give us a little insight on that, because I don't have the details. But I think that's something that's coming to the task force. Is we're going to be looking at that study of those caseloads of our public defense system. So really, that's all I have for steering, Jack. Or Stephen, you got this one, yeah.
Okay, thank you, Barry. So as I said, we're going to pass on behavioral health and hear an update next month on that. And I think, I don't have my agenda in front of me, but I think that gets us to public comment.
Correct. Yep, that's where we are.
So Jill, would you invite public comment, please?
Yes, of course. We do have a few attendees in our meeting today.
Jill, maybe before we do that, Stephen, you want to do that little, or I can read it, or you can read it, the little.
Oh, yes. Yeah.
I've got it in front of me, or unless you have it handy.
I've got it.
Cool.
Per RCW 42.17A.555, the use of public facilities to support or oppose candidates or ballot issues is prohibited. Members of the public and this body are not allowed to speak in support of or in opposition to a ballot measure or individual candidacy during an open public meeting such as this. Please refrain from raising campaign issues when addressing the task force. So Jill, I see one hand up.
Hi, am I there? Can you hear me?
You were very,
Yes, you can.
yeah, now we can hear you, Jason.
Okay, excellent. Hi, good afternoon, folks. Jason Forrest, local business owner. The BIABC now, which is the Bellingham Building Industry Association of Whatcom County. Just wanted to let you guys know what I think her name was Kelly. Wow, what a great presentation she gave. And we over at the building industry, I'm sure, would be more than willing to work with you guys on any situation you need as far as building houses for the people in our community go. I'm sure it's a tight-knit group over there, and all you'd have to do is reach out, and we could work together to get these houses built. I think that you guys need to refocus your energy away from that 12-hour hold thing. It seems very civil rights violation-y. And why get your hands dirty with something like that if there's better options, better things to do? If you could all redirect your efforts into things that are more productive, that would be great. We need to hold police and healthcare workers accountable. Really need to say that again. Thank you very much for your time.
Thank you, Jason.
Thank you,
Jill,
Jason.
any other public comment?
If anyone else would like to speak to the task force, please virtually raise your hand now. And no hands are raised, and I don't see anyone in our conference room.
Okay.
And if I could have Jenna stay following the meeting, that would be great.
I think we are at the end. We've done public comment. Stephen, you don't know this yet, but I'm going to be in Arizona in November, likely without internet. So I look forward to seeing you all in December. And thanks everyone. We are, any reason not to adjourn, Stephen?
No, I think
All right,
we're ready.
we are adjourned 30 minutes early. Enjoy your extra half hour, and thanks to everyone for being here.